Guillain-Barré syndrome is a autoimmune disorder. It's a neurologic autoimmune disorder. Just like any other autoimmune disorder, we have no idea what causes it, so there's really no cure. We can control it. It's not a permanent disease, okay? It is self-limiting. So this is a form of polyneuritis. There are many types of polyneuritis, meaning weakness and paralysis syndrome. So this is just one of them. It's autoimmune. The problem is going to affect symmetrical parts of the body. The pattern is ascending weakness and paralysis. So it's commonly known as it starts from the toes and up it goes. Okay? Starts from the toes, up it goes. Unlike multiple sclerosis, which started from the eyes, correct? This one would start from the toes and goes up. Usually if the patient does not seek medical intervention within 2 weeks from the onset of symptoms, we cannot stop the progression. So the patient will eventually have diaphragm paralysis and will be on a ventilator. 2 weeks. Correct. All right. So the problem, again, it's ascending weakness, starts from the toes. So most stories are when we see these patients, they just got up one day and then fell because they did not anticipate that their feet were weak. Okay, so they just got up one day, sat on the side of the bed, got up, and then fell on their face. Okay, they couldn't anticipate, oh, why was like their legs just gave away. And they usually brush that off, just tired. And then 2 weeks later, the patient's now unable to breathe independently. Okay, they're in respiratory failure already. Until then, these are the manifestations: hyporeflexia, paresthesias. You know paresthesias, right? Okay. Yeah, numbness, tingling. The event is usually preceded by something viral, meaning they had either even a vaccine, a flu vaccine, a viral vaccine, can also trigger the episode. It doesn't happen to everybody. I mean, it's rare, but we know that something happened a few weeks before the paralysis or the weakness onset. And these are the known precipitating events. They had a Campylobacter jejuni infection, cytomegalovirus, Epstein-Barr, mycoplasma, the flu, or even Zika virus. And like I mentioned, even the flu vaccine. So some patients had a flu vaccine 2 weeks before the onset of the symptoms. There are many types of Guillain-Barré syndrome. We'll only talk about the most common type, which is the classic ascending paralysis. So 1 to 2 cases per 100,000 people. So that's quite rare, right? The only person I saw here with this was a huge guy. He was almost 300 pounds. He was a nursing home patient, got a flu vaccine 2 weeks before, and then he had the symptoms afterward. Because it's autoimmune, so do we know the cause?
No.
Is there a cure?
No.
No, but we can halt the progression though with one of two interventions. We'll talk about that shortly. As already mentioned, these are the manifestations. So there's demyelination of the nerves. Weakness is usually the early symptom, and then it progresses upward, and then the patient will end up with paralysis. Let's go straight to diagnostic. There's really no definite test that will tell us, oh, this is Guillain-Barré syndrome. All the diagnostic tests done here is simply to rule out other possible causes. So they'll do an EMG, they do a CAT scan of the spine, they'll do some spinal tap just to examine, is this because they resemble also meningitis, so other viral or other spinal nerve conditions. So as soon as they eliminate those, they rule them out, then we arrive at a diagnosis of Guillain-Barré syndrome. Management. Only one of two treatments will work. The other treatments are simply supportive. Let's say the patient already has respiratory failure, ventilatory respiratory failure, so we will have to intubate the patient and place them on a ventilator. The treatment are one, therapeutic plasma exchange. This is the cheaper option. I think I mentioned this last semester. So this is plasmapheresis. Since this is an autoimmune disorder, meaning it's the patient's own antibodies attacking the myelin sheath, causing the symptoms and the paralysis. Therefore, we will remove the patient's plasma, which contains majority of the patient's antibodies, replace it with someone else's plasma. So that's the cheaper option. Of course, when we do plasmapheresis, that means you'll need a central line for, because it works like hemodialysis. Or we put in a fistula. Well, the dialysis catheter, of course, will be the faster option here because we're pressed for time, so there's no time for creating a fistula or a graft. The other expensive option is the IVIG. So this is the infusion of immunoglobulins. So these are antibodies. See, there's a good antibodies to counteract the patient's auto antibodies. So only one of two. I know this says here and, but they're not given together. Doesn't make sense. Okay, it's not cost effective. One has the same effect as the other. Okay, one is not better than the other. Does that make sense? Okay. So we don't do both, okay? But it's either option, right? But these are the only therapies that will shorten the pattern of the syndrome. As I mentioned, the other interventions here are simply supporting someone with decreased mobility. So they're weak and paralyzed, so they can't get out of bed, so they're at risk for pressure injuries, DVTs, hypercalcemia, urinary retention. Okay, I already mentioned hypercalcemia, yeah? Cardiac issues, okay, all the complications of immobility, including respiratory, okay, pneumonia. That's about it. The other interventions here, as I mentioned, are simply supportive. Any questions on Guillain-Barré syndrome? Okay, let's proceed with lupus.
What, 2104?
There are two types of lupus. The less common form is discoid lupus, which is better than the systemic type. For discoid lupus, the patient only has the skin manifestations. It's still going to bother the patient, of course. They will have this rash on their face and other parts of the body. However, for this topic, we'll only focus on the systemic type, systemic lupus erythematosus. So it's an inflammatory autoimmune disorder. This is chronic. There is no cure for lupus because, again, it's an autoimmune disorder. We have no cure for autoimmune disorders because we don't know what causes it. We have no cure, therefore. Because we don't know the cause, all we know is that it's a autoimmune, which means the patient has antibodies which will attack connective tissues in the body. Now, name a body system that doesn't have a connective tissue. Name one. None. Okay, there is no body system that doesn't have connective tissue. We are covered in connective tissue. We have no connective tissue, then we will fall apart. So what are connective tissues? So you know joints, ligaments, right? Blood vessels are connective tissues. Hair, skin are connective tissues. Every solid organ has connective tissues. Okay, so therefore, there's no body system that is not affected by systemic lupus. Because it's a chronic condition, the goal of treatment will be to put the patient on remission as symptom-free as possible and monitor them for complications and then treat flare-ups. Because just like any other chronic condition, heart failure, diabetes, kidney disease, they will have exacerbations, correct? Like COPD, so they will have flare-ups. Okay, we'll look at the triggers also, what will cause a flare-up. Because the largest connective tissue in the body is the skin is usually the first trigger. When exposed to ultraviolet rays of the sun, that's enough of a stressor to trigger a flare-up. Another is stress, which is it's very relative, it's very vague, highly unique to each patient. So whatever is stressful to a person with lupus can trigger a flare-up. So some triggers mentioned here are cigarette smoke. I already mentioned ultraviolet rays, certain medications, viral infections, emotional or physical stress like surgery in pregnancy, and silica dust. Manifestations, as I said, we are covered with connective tissue from head to toe. So there will be hair, skin manifestations. There will be manifestations in every organ of the body, every solid organ. So we will have arteritis as well. So this will involve headaches as well. So here's the picture from head to toe. Patient will have manifestations. The more serious ones, of course, are kidney failure. This will cause chronic kidney disease, and the patient will sometimes lose their kidneys. Okay, they'll go into stage 5 CKD and then end up on hemodialysis. We call that lupus glomerulonephritis or lupus nephritis. There is pericarditis. So this is one of the non-cardiac causes of pericarditis, non-viral, non-infectious cause. If you remember from last term, there were 3 causes, right? We had a heart attack, then we had infectious causes of pericarditis, and this is the inflammatory cause of pericarditis. Patient will also have pneumonitis, meaning every single sac in the body will be inflamed. So the fascia are connective tissues as well. So there will be some muscle pain, which is myositis. We have joint pain here because all joints are connective tissues. Okay, so is this a debilitating condition? Excuse me. And remember, the bone marrow is also encased in connective tissue. So there will be some bone marrow suppression here as well. On the skin, just like the discoid lupus, patient will have the classic butterfly rash over the bridge of the nose and over each cheek. There will be hair loss, mouth ulcers. Okay, so head to toe, it's a sad disorder to have. Diagnosis, just like Guillain-Barré, just like rheumatoid arthritis, there's really no specific test that will diagnose lupus. Because the manifestations early on resemble rheumatoid arthritis, that may be the patient's initial diagnosis. So patients will be treated for rheumatoid arthritis early on, and then until later when they start manifesting symptoms of kidney failure, then the patient will undergo further testing and then change the diagnosis to lupus. I already mentioned the manifestations. I'll go through that. Let's go to management. So this can be life-threatening. As you know, the complications were pneumonitis, right? Pericarditis. So those are the serious ones, plus not to mention acute kidney injury, because they can't be on top of CKD. Patient may have AKI initially because of the inflammation of the nephrons. of the kidneys. As already mentioned, goal of treatment is to put the patient in remission as symptom-free as possible, because this is again an autoimmune disorder, so this will involve what drugs? Immunosuppressants. So similar to medications we used in rheumatoid arthritis last semester, the TNF inhibitors, tumor necrosis factor inhibitors, interleukin-1, interleukin-6 inhibitors, those types of medications, okay? More cell-specific. Yes, methotrexate can also be used. However, during exacerbations, just like in rheumatoid arthritis, we will place the patient on short-term steroids, high-dose steroids during exacerbations. So besides putting the patient on remission, we also want to monitor the patient for complications, again, from kidney failure, and also the more serious ones, which are pericarditis, pneumonitis, and then pain is a classic complaint. So patient will have fatigue, pain, joint pain. Patient will also need chronic pain medication. For this purpose, what would benefit the patient? Because this is a chronic inflammatory autoimmune disorder. So what pain medication would be appropriate here? Anti-inflammatory drugs, analgesics, which is NSAIDs. So let's start. So for pain, the patient will be on NSAIDs for the modifying the nature of the disease, meaning to put them on remission. We use expensive monoclonal antibodies, so steroids for exacerbations. Then we have antimalarial agents. Remember hydroxychloroquine, which we use in rheumatoid arthritis, and immunosuppressants. We have a table, which is, I think it's further down. Okay. I already mentioned steroids will be reserved only for exacerbations. However, for the skin rash, patient may be prescribed a steroidal cream that will help. And also they're also encouraged to, because this will bother the female, right? I mean, imagine you're 20 years old, you have this rash over your face, screaming at all the guys, right? And you're single. So you can cover it up with cosmetics, with moisturizers. Okay, so you invest in cosmetics with good moisturizers, right? So because again, the skin is the largest connective tissue. This will get, if you get harsh ingredients on it, so you will make it worse, and then you'll have a flare up. I know it's only for short term because the rash will disappear after a few days of treatment. Hydroxychloroquine, side effects here is, of course, there are cardiac dysrhythmias, and also this will cause some eye problems as well, vision problems, sorry. So make sure the patient gets a baseline eye exam first before starting hydroxychloroquine. These are the most commonly used immunosuppressants. So mention methotrexate, and then we have cyclophosphamide, azathioprine, mycophenolate. Some of these, especially cyclophosphamide and mycophenolate, if you remember last week when we talked about organ rejection, these were also used. For nursing care, we forgot the incidents. So who are affected by lupus? Here under incidents, the mostly females, and the peak is around 20 and 40 years of age. So how do you describe 20 to 40-year-old females? What are you doing between 20 and 40? Okay, what else? Okay. What else? Your career, right? Your career women, right? You're not in menopause yet, so you're in your most productive years, and then you're inflicted with lupus. How do you think you'll feel? Yeah, you'll be like, what? I don't believe this, right? So you'll have all this social isolation. You can't go out to you can go to the beach, but you have to stay under a big umbrella, wear, as much, a really big hat, stylish big hat, um, good sunscreen, okay, SPF, I would go with 50 or higher, okay, to protect your skin from, remember, ultraviolet rays are a trigger. Okay, so emphasize skincare for these patients. So protection from the sun is very important. Avoid other triggers. So we mentioned cigarette smoking or other pollutants can exacerbate the condition as well. How hydroxychloroquine works is, I know it's an anti-malarial agent, but of course this patient doesn't have malaria, right? So the drug, however, prevents your skin from absorbing ultraviolet rays. So because of that property, that's what makes it effective for people with lupus. Okay, so that's the rationale for using the antimalarial agent. Because again, the skin is the largest connective tissue, so the minor exposure to UV rays can already cause a trigger, okay, for an exacerbation. So can you absolutely avoid UV rays?
No.
No, unless you live in a basement somewhere in a cave, right? But whenever you're out, remember these women are 20 and 40 years old, so they are up and about. They're working, so they have to take the hydroxychloroquine. Here's screening for osteoporosis because these patients will, of course, have frequent exacerbations and will be placed on steroids quite frequently throughout in a given year. So the chronic steroid use, besides Cushing syndrome, they will also have osteoporosis. So we screen for that. We get ready that these are inadvertent consequences of the therapy. Some patients may also have primary Sjogren syndrome. I'll just include this, but I'm not testing it. Okay, let me just describe this syndrome. This will cause dryness of everything. I mean, imagine every orifice in your body that has lubrication. So from your ears, your nose, your mouth, um, your nasal passages, your GI tract, your reproductive tract, all of these have mucus, right? So all of them will dry up. So how will that feel? So we have painful intercourse. Okay, you'll have mouth sores as a result. Okay, so this is on top of the lupus. Some rheumatoid arthritis patients also may occasionally report this condition. Treatment, nothing really. So we just lubricate. If it's affecting the eyes, then we use eye drops, extra lubricant for sexual activity. There's not much we can do. Okay, so we just do support it. Okay, so lubrication. Let's say you have dry mouth, then use Biotene, right? Artificial saliva. Right here. So Biotene, that's all we could do for if you have this syndrome. And good thing it's rare though, but people with lupus or rheumatoid arthritis tend to have this condition. That's it.